It is 1 o'clock, and we welcome you to the ICD Logic and PACOM Partnership presentation, Seize the Power of Clinical Documentation Guidance While You Learn ICD-10. We're pleased to have the opportunity to provide valuable resources and information to PACOM members and others in solo physician and small group physician practices. PACOM membership provides even more support, but at least these webinars are free to all of you and can be viewed afterwards via our YouTube channel, which is open to the public at youtube.com/PACOM. Attendees of today's live webinar broadcast will receive presentation slides in their registration email accounts after the webinar. We encourage use of the recorded webinar in conjunction with the slides, as the presenter's spoken points are significant and the slides alone do not include all of the information. See the left side of your screen for the chat box. Use that for your questions. You do not need to wait to ask them, but the speaker will likely answer them toward the close of the presentation. One CEU has been approved for this live webinar, hosted at 1 p.m. Eastern on February 18, 2015. Unfortunately, we cannot award CEUs for viewing the recorded version. That's all for general information and housekeeping. Now we can move on to the webinar. It is my pleasure and honor to introduce the first of two expert presenters for today's webinar. Monique Fayad is the CEO and co-founder of ICD Logic, a healthcare technology company focused on clinical documentation innovation. As former VP of e-products and business development at Severity Health Sciences, the world's largest healthcare publisher, she conceived, built, and launched 3 major information-driven healthcare solutions for clinical markets, including CardioSource and Oncology Stat. From 2010 through 2012, Monique directed corporate strategy and e-solution development for HC Pro, a leading U.S. healthcare regulatory information and education provider focusing on revenue cycle, clinical documentation improvement, and ICD-10 education. Monique has a degree in marketing cum laude from Chestnut Hill College and an MBA from Leonard N. Stern School of Business at NYU. Please join me in welcoming Monique Fayad, who will introduce her co-presenter, Dr. Wilbur Lowe.
Great. Thank you so much for that great intro, Karen. Welcome to today's webinar aimed at showing physicians how they can learn ICD-10 today while they work and sharpen their clinical documentation skills at the same time. I'm Monique Fayad, the CEO and co-founder of ICD Logic. And before we begin, I'd like to introduce my esteemed colleague who's joining me for this webinar, Dr. Wilbur Lowe. Dr. Lowe is an educator, author, and lecturer in the field of clinical documentation improvement, also known as CDI. Dr. Lowe obtained his medical certification in pathology from Vanderbilt University Medical Center and his MD at the University of Toledo College of Medicine. Dr. Lowe is an AHIMA certified CDI professional and is currently an adjunct professor in the Health Information Management Department at Temple University in Philadelphia. He also chairs the CDI Advisory Board at ICD Logic and oversees CDI content development for our software tool, Cipher. Will?
Thank you, thank you, Monique. Yes, I am Dr. Wilbur Lowe, a CDI educator and pathologist. Together, we'll connect the dots to help our audience understand the negative impacts of poorly coded patients and how easy it is to seize the power of good clinical documentation.
And we'll demonstrate an innovative new software tool, Cipher by ICD Logic, that enables clinical documentation improvement while teaching ICD-10 concurrent with care. After the lecture and demo, we'll give you information on how to obtain your CEU credits and also explain how you can participate in a free trial aimed at helping physicians understand how affordable, easy, and fast workflow tools like Cipher can help make ICD-10 a non-event. So why don't we go ahead and get started? You should be seeing the agenda slide now. Right now, I'd like to begin the webinar by talking about some of the impacts of chronic illness in America. Then Dr. Lowe will present some case scenarios discussing the concept of severity of illness and review some startling research about the unintended consequences of poor documentation. Then he'll share his perspective on some of the root causes of poor clinical documentation. I'll wrap things up by showing you how you can use CDI software tools to maximum advantage. Discuss 4 chronic conditions. I'll take you through asthma, diabetes, chronic kidney disease, and a femur fracture. And then together, Dr. Lowe and I will present strategies to help sharpen clinical documentation skills in preparation for ICD-10. At the conclusion, we'll be pleased to answer any questions you may have. Before we begin, let's ground our discussion by looking at the size and demographic composition of the U.S. population. As of today, the U.S. population count is approximately 320 million people. Now, while this chart's from 2010, it helps you visualize the distribution of Americans by age category. And as you can see from the arrows on the right, and especially to the upper right, about 12.8% of the U.S. population is currently age 65 and older. Every 10 years, a tier of those 65 and older is growing larger. In fact, over the next 15 years, 10,000 baby boomers will turn 65 every day. America clearly has an aging population that's living longer, and it can become a great burden to our healthcare system because multiple chronic conditions are steadily becoming the norm. In addition, poor choices in diet, personal risk behaviors relating to exercise and smoking and drinking are all taking a toll on Americans regardless of their age. Sadly, in 2012, half of all adults had one or more chronic disease and 25% had two or more. 7 of the 10 causes of death, top 10 causes of death in chronic diseases are heart disease and cancer. These two account for 48% of deaths. High rates of obesity in adults and children and the continued prevalence of smoking and drinking are adding to the overall health problems that our nation faces. Comorbidity is defined as a combination of 2 or more chronic conditions in a patient. These conditions may be pathogenically related to each other or coexisting in a single patient independent of each other. What's important to know is that many comorbidities are never documented accurately inside the patient record. So let's talk about how treatment of chronic conditions burdens our healthcare system and how better clinical documentation is essential. Dr. Lowe will begin with a simple case scenario.
Yes, thank you, Monique. I want to begin by reviewing some important code sets for ambulatory care services. Coding can be confusing, and when not done properly, clinicians are not fairly reimbursed for their work. It is estimated that last year, physicians left over $1.5 billion unclaimed dollars for services they legitimately provided. The Healthcare Common Procedure Coding System, HCPCS Level 1 codes, are referred to as the CPT-4 codes and are maintained and updated by the American Medical Association, AMA. The HCPCS Level 2 codes are the non-CPT-4 codes and include codes for ambulance services, surgical supplies, durable medical equipment, chemotherapy drugs, vision, and hearing services. You may have heard about CPT. Specifically, it is known as CPT-4, which refers to Current Procedure Terminology, 4th edition, and is used by physicians to report services and procedures performed in the inpatient and outpatient setting, as well as by facilities for outpatient services and procedures. Use of the CPT-4 codes, if linked to the proper ICD-9 or ICD-10 diagnosis codes, will lead to proper reimbursement for services and procedures. The International Classification of Disease, ICD-9, codes both in the 9th and 10th editions are created by the World Health Organization and then modified by each country that adopts them. So ICD-10 in Canada is slightly different than ICD-10 in America. These codes are maintained by the Centers for Medicare and Medicaid Services, CMS, which is one of the 4 cooperating parties for the ICD-9 and ICD-10 code sets. CPT-4 Category 1 codes are known as the permanent codes and include 6 sections: evaluation management, known as EM codes, as well as anesthesia, surgery, radiology, pathology and laboratory, and medicine. I want to discuss the EM codes that are used for the physician's time and expertise. Most of the EM categories and subcategories are further divided into 3 to 5 levels of service. The higher levels correspond to more complex patient encounters. For instance, a Level 1 EM service deals with a problem-focused history and examination with straightforward medical decision-making, such as poison ivy, whereas a Level 5 EM service deals with a comprehensive history and examination with high complexity medical decision-making, such as septic shock with multiple organ failure. In this scenario, The physician performs an EKG and a series of lab tests to rule out an acute myocardial infarction, but makes an entry of chest pain instead of acute myocardial infarction in the patient's record. If the physician does not respond to a coding query, the coder must assign the diagnosis code for chest pain. According to inpatient coding guidelines, an acute myocardial infarction is a major complication and comorbidity, MCC, which means that it will be assigned a higher severity of illness score and require increased utilization of resources, leading to increased reimbursement for the facility, whereas chest pain will result in lower reimbursement that does not reflect the utilization of resources. According to the Healthcare Cost and Utilization Project from the Agency for Healthcare Research and Quality, AHRQ, the median hospital cost to treat an acute myocardial infarction averages around $19,000, compared to about $4,800 for chest pain. This is the hospital cost, not the actual amount paid by the third-party payer, which is even more striking. Also, this does not include the physician's fees. In the previous slide, I discussed EM codes for CPT-4 coding. In this scenario, the provider reimbursement for a Level 2 inpatient EM consultation is $78 for chest pain, compared to a Level 5 inpatient EM consultation of $208 for an acute myocardial infarction. Clearly, incomplete or improper documentation can adversely impact treatment and reimbursement for facilities and providers. Clinicians rely on information to provide proper treatment. If information is missing in a patient's medical record, the clinician will be required to waste precious time to locate the information. This may affect the quality of patient care. A sick patient requires more resources. If a clinician does not properly document the patient's condition, the patient may appear less sick, and the clinician may be questioned as to why resources are being overutilized. The clinical language does not translate directly into the coding vocabulary. Significant gaps exist between the clinician's knowledge of disease processes and the novice coder's ability to navigate through the chart and abstract the proper diagnosis and procedure codes. Disconnects between a clinician and coder may lead to claim denials and audits if the coder inadvertently assigns diagnosis codes that are not linked to the procedure codes. For instance, a clinician performs an angiography to detect a possible pulmonary embolus in the left pulmonary artery, but the patient is also being treated for a urinary tract infection. If the novice coder assumes that the angiography is for the urinary tract infection and does not capture the diagnosis of pulmonary embolus, the insurance claim and payment will be denied. I want to discuss the Resource-Based Relative Value Scale, RBRVS, which is the federal government's payment system for physicians. By creating the RBRVS system, the rates of reimbursement for services of general practitioners for office visits and consultations were increased to rates comparable to specialists. RBRVS is a complex reimbursement concept that classifies physician services based on the setting, the skill and training required to perform the services, the time, and the risk involved. RBRVS is based on the codes listed in CPT-4. The Medicare Physician Provider Fee Schedule formula for RBRVS is based on the RVUs, GPCI, and CF for each CPT-4 code. RVUs, relative value units, are based on physician work, practice expense, and malpractice respectively. GPCI, Geographic Practice Cost Index, is an adjustment for variation due to location. This means that a colonoscopy will be more expensive in San Francisco than in Pittsburgh. CF, conversion factor, is a multiplier based on the Sustainable Growth Rate System established by the Centers for Medicare and Medicaid Services. In short, complex CPT-4 procedures will have higher values of RVUs and GPCI. Multiplying these values by the conversion factor will lead to increased physician reimbursement. The ICD-9 and ICD-10 diagnosis codes will justify the medical necessity of the CPT-4 procedure codes and will result in appropriate reimbursement for the physician. Assume that a physician performs an extracorporeal shock wave lithotripsy, in which powerful shock waves are used to break apart kidney stones. If the physician makes a non-specific diagnosis of low back pain instead of kidney stones, the insurance company may deny payment because the diagnosis of low back pain did not justify the use of the lithotripsy procedure. Low back pain is treated with analgesics or muscle relaxants, not a major lithotripsy procedure. Now, let's switch from the codes to the actual conditions represented by diagnosis codes. In 2010, the Department of Health and Human Services became so alarmed by the prevalence of chronic conditions that it started an initiative to build a 4-part strategic framework to address this issue. As seen in blue font, the third part of the framework involves equipping healthcare providers with tools, information, and other interventions. In 2012, 8 planks were established to support the framework. Plank number 5, integrating MCC, multiple chronic conditions, into clinical practice guidelines, is particularly germane to our discussion and is a challenging task. I want to point out that MCC can stand for multiple chronic conditions as well as for major complications and comorbidities, which relates to inpatient reimbursement. This chart is one of the tools made available through the HHS Multiple Chronic Conditions Initiative. It is part of a Medicare beneficiaries chart book, an interactive website that is frequently updated and allows all providers to follow the progression of chronic conditions at the state and national levels. In this chart, the top 15 chronic conditions are listed by prevalence. It's not a pretty picture. In fact, it's frightening. Medicare currently covers 54 million Americans, so data from 2012 would represent approximately 49 million Americans. And this chart does not represent chronic conditions of the 69 million Medicaid enrollees or of all other Americans under age 65 not insured by Medicare or Medicaid. 6 in 10 Medicare beneficiaries have high blood pressure. That's nearly 30 million people. To put that in perspective, 30 million is about the size of the entire population of Canada. 45% of Medicare beneficiaries have high cholesterol, and 28% of beneficiaries having diabetes is particularly troubling since it is challenging to treat the complications of diabetes. As beneficiaries age, they suffer from more chronic conditions. Unfortunately, poor choices in diet and exercise early in life lead to problems later in life. I want to focus on the bars enclosed in the red box in the far right column. According to the purple bar, 25% of the beneficiaries over the age of 85 suffer from 6 or more chronic conditions. But as you're about to see in just a few minutes, this data is only as good as the documentation of these conditions in the patient's chart. Evidence is mounting that codes are not assigned for many chronic conditions in the patient's charts, regardless of age. As one might expect, patients with more chronic conditions have a greater chance of being hospitalized. Each column represents the number of chronic conditions from 0 to 1 to 6 or more. Note the purple boxes at the top of each column. On the far right column, 16% of beneficiaries suffering from 6 or more conditions were hospitalized 3 or more times in 1 year. Looking once again at the purple box on the far right column, 27% of the beneficiaries with 6 or more chronic conditions had 3 or more visits to the ER. Healthcare reform has pinpointed hospital readmissions as a key area for improving coordination of care and achieving potential savings.
the CMS Hospital Readmissions Reduction Program has selected acute myocardial infarction, heart failure, and pneumonia as target areas for the Medicare population. CMS chose these conditions in part based on their high prevalence and their associated high cost for total admissions and readmissions among Medicare beneficiaries. Next year, CMS will target additional conditions that represent high volume and cost. As you realize, emergency rooms are hectic, and it's very challenging to balance patient care and paperwork. So I suspect that these numbers might be underreported and that the actual number of people with multiple chronic conditions, whether 0 to 1 or 6 or more, is greater in each column shown on this chart. Obviously, healthcare for sicker patients costs more money, so again, it is not surprising that patients with 4 or more chronic conditions represent 37% of the beneficiaries, yet account for 74% of Medicare spending. In 2011, Medicare patients accounted for 56% of all readmissions and cost the taxpayers $4.3 billion in hospital cost. This is staggering. Let's look at another case scenario. This simple dialogue between physician and coder helps illustrate how documentation of comorbidities reflects severity of illness and facilitates proper reimbursement in the inpatient setting. Medicare severity diagnosis-related groups, MSDRGs, have relative weights corresponding to the severity of illness and the intensity of resource utilization in the hospital. MSDRGs are comprised of 3 tiers: major complication and comorbidity, MCC, complication and comorbidity, CC, and no complication and comorbidity, non-CC. A MCC will increase the length of hospital stay by several days in at least 75% of the cases. DRG 682, a patient with renal failure with a MCC, is estimated to utilize 3 times as many resources as DRG 684, a patient with renal failure with no MCC. Beyond reimbursement, documentation of complications and comorbidities helps to present a more accurate picture of population health management. Physicians are not that different from other workers when it comes to on-the-job paperwork. For many years, there were no standards governing physician notes in the patient chart or the documentation of chronic conditions and comorbidities. This led to a wide variation in the quality of physician notes. Even as our work becomes computerized, there are thousands of different EHR and practice management software programs, and each captures chronic conditions in a slightly different way. Numerous research studies show that problem lists can be an Achilles heel for many software vendors. I wasn't surprised by the charts that I'm about to share with you next, but I certainly was shocked to see the pivotal role played by good documentation in quality patient care and better allocation of healthcare resources. In a quest to better understand the scale and implications of uncoded patients, a team of researchers at Humedica, a data mining company now owned by Optum, sifted through data from over 4 million actively treated patients who had evidence of major chronic conditions, but who did not have any corresponding diagnosis codes on their claims or EHR problem list. Based on evidence from lab results, progress notes, clinical outcomes, and prescribed medications, Humedica determined that 37% of patients with evidence of diabetes, congestive heart failure, coronary artery disease, hypertension, or dyslipidemia were not assigned diagnosis codes for one or more of these conditions. That sure caught my attention. In other words, approximately 17% of the patients in a typical medical practice are uncoded for at least one major chronic condition. If a medical practice serves 500,000 patients, about 83,000 patients are not assigned a diagnosis codes for one or more chronic conditions. These findings appeared in the September 2013 issue of The Collaborative, a newsletter published by Humedica. These patients were described as relatively sick, with nearly half showing evidence of more than one chronic condition. As you might expect, uncoded patients typically have lower rates of utilization of health care, regardless of condition. The Humedica article suggests the rate of primary care utilization, which are PCP visits, for uncoded patients can be as much as 73% lower, as illustrated by this chart, for diabetes patients. In fact, ambulatory visits at all evaluation and management levels, especially level 4 and 5 visits, are lower. Notice on the right-hand portion of the chart that acute care utilization among diabetic patients is higher. Uncoded patients have 30% more emergency room visits and 45% more inpatient visits, with 33% more average length of inpatient stays. This data suggests that a significant opportunity exists to identify uncoded patients to reverse the pattern of utilization of acute care and to shift toward the utilization of proactive ambulatory care, which is focused on preventive care and is less expensive. In this chart, Humedica followed newly coded patients along with a cohort of always coded and never coded patients for 1 year. They found dramatic improvements when previously uncoded patients became newly coded across the following chronic diseases: diabetes, congestive heart failure, hypertension, dyslipidemia, which means elevated cholesterol, and coronary artery disease. As you may recall from a previous chart, hypertension has a prevalence of 58% with respect to chronic conditions among Medicare beneficiaries. In this study, 68% of hypertensive patients newly coded experienced clinical improvement versus 50% for those always coded and 52% for those never coded. Just imagine how we could improve patient health and decrease resource burdens if these diseases were coded 100% of the time. I spoke earlier about the serious complications of diabetes, which can affect multiple organs and lead to heart disease, stroke, kidney failure, blindness, amputation, and conditions affecting the quality of life. This study showed that for newly coded diabetic patients, the clinical improvements were across many different measures, including lipids, A1C, and systolic and diastolic blood pressure. The improvement of the hemoglobin A1C in newly coded diabetic patients was especially significant. The A1C test measures the percentage of glycosylated hemoglobin, which means hemoglobin that is coated with sugar. Hemoglobin is a protein in red blood cells that carries oxygen. The higher A1C levels are correlated with poorer blood sugar control and higher risk of diabetes complications. Why was there such a significant improvement in newly coded diabetic patients? Here's what the authors had to say. In year 1, utilization increased for all types of clinical services. Annual outpatient visits per patient increased from 2 to nearly 6, the same rate seen in patients that had always been coded. The PCP visit rate nearly doubled, and the rate at which they saw endocrinologists and cardiologists more than doubled. There were also increases in ER and inpatient visits. This widespread increase in utilization likely occurs as patients become more integrated into the health system or practice, and their level of care is right-sized relative to their need. In contrast, utilization decreased across the board for uncoded diabetes patients. Their use of the health system was low to start with, and it decreased further. Now that we've seen some evidence concerning uncoded patients who become newly coded, let's take a moment to discuss the reasons why physicians don't always provide adequate documentation. But first, let me use a third scenario to compare good versus bad documentation of comorbidities. Consider these two examples of documentation for the same patient with asthma. At first glance, the upper caption appears smaller than the lower caption, which suggests that it may be missing some vital information due to incomplete documentation. Upon closer examination, the lower caption indicates that the patient had status asthmaticus, as opposed to an asthma attack described in the upper caption. Status asthmaticus is a complication and comorbidity, CC, and requires increased utilization of resources and will lead to increased reimbursement for the facility. Intellectually, physicians understand the value of documentation, but because physicians do not take courses in documentation and are not formally trained in documentation, physicians approach documentation differently and with various levels of commitment. Second, it's hard to engage physicians and gain commitment if documentation is not part of the ingrained workflow, especially if it's not well understood and remains an enigma. Increased paperwork requires physicians to see more patients in less time just to keep pace with cuts in reimbursement. Physician productivity plummeted with the adoption of the electronic health records, and many physicians are just plain burned out. Fourth is the antiquated query system. If physicians can have a better understanding of the correlation between proper documentation and coding, the query system would disappear. There are no baseline standards imposed on EHR and practice management systems, and many do not focus on documentation in ICD-9 or ICD-10. After 30 years, many providers have memorized the ICD codes most relevant to their patient population, and the media and special interest groups have done an injustice by inaccurately portraying ICD-10 and striking fear in the physicians' minds. Actually, ICD-10 is an intuitive code set with specificity that is aligned with evidence-based clinical guidelines. At this point, I want to turn it over to Monique.
Great. Thank you so much, Dr. Lowe, and thank you for all that great information. Dr. Lowe, one thing I hear frequently from healthcare providers is that the increased documentation to support ICD-10 coding is an unnecessary administrative burden that's going to weigh down the practice. But if we look closer at the types of documentation needed to support proper coding in ICD-10, you can quickly realize that the required documentation is an important part of good patient care. If we look at any of the documentation requirements to support ICD-10 coding listed on the right-hand side of this slide, they're pretty straightforward. And yes, the number of codes is increasing, as you can see by the chart on the left, but for logical and sound clinical care reasons. The red box calls out how ICD-10 requires clinicians to note site specificity and laterality. Just by indicating whether a condition affects a bone, muscle, or organ on the right or left side of the body accounts for 25,000 of the new ICD-10 condition codes. So how difficult or unnecessary is that? Let's take an example here. We'll look at the thigh bone or femur, which is a very large bone in the body and has some very distinct anatomical features. It stands to reason that a fracture of the head or neck of the femur may require different care than a fracture of the shaft. ICD-10 merely asks the orthopedist to explain where the fracture occurred and which leg is affected, right or left. When you think about the number of codes increasing, it's logical to see that documentation of site specificity is just part of practicing good medicine. We can also look at some of these examples that have to do with etiology and medical manifestations. ICD-10 asks the clinician to document other medical conditions and common signs or symptoms. understanding if something is due to or manifested by can be incredibly helpful for the provision of care and for accurate documentation. And, you know, what about all these crazy things we hear in the news about skis on fire and being bitten by an orca? Well, many people would be surprised to learn that many of those same codes and descriptions are included in ICD-9 today. There's a funny cartoon that Relay Health put together, and sometimes I chuckle at it because people always seem to characterize ICD-10 as a coding problem. You know, at ICD Logic, we believe fundamentally that ICD-10 is a documentation challenge, and it doesn't matter if ICD-10 happens this October or next October or whenever. The time to do a better job of documenting is now, even in ICD-9, which you could see in that Humedica study. And now, today, in 2015, there are so many tools available to help everyone sharpen their documentation skills more easily. I'd like to talk for a minute about a new generation of computer-assisted clinical documentation improvement tools. As you can see, we refer to them as cacti, not the prickly type. These tools can help eliminate the need for expensive training by integrating documentation into the workflow. So they include custom indexes that fix the gaps in the current GEMS mapping programs. And as Dr. Lowe mentioned, many of the current electronic health records ICD-10 solutions or problem lists are doing a poor job of offering clinicians clinical documentation guidance, especially when it comes to identifying important underlying factors and common complications and comorbidities that they need to be thinking about and make sure they document in the record. That's why we're so proud of the system we'd like to show you now. It's called Cypher, and it helps you select a condition, specify according to the new documentation requirements of ICD-10, and guide you to think about additional factors, complications, and comorbidities as you're documenting. Cypher from ICD Logic helps you select a condition, specify according to the new requirements, and document additional factors and complications. In 3 easy steps and less than 30 seconds for most conditions, it helps you generate best-in-class documentation for both ICD-9 and ICD-10. So you can actually use it today while you ramp up for ICD-10 coming in October. I'm going to take just a few minutes to show you how Cypher specifically documents 4 conditions, the 4 conditions listed here. And then Dr. Lowe, after that, Dr. Lowe and I will summarize several ways that you and your practice can help sharpen documentation skills today within your clinical team. So let me just take a moment here, and I'm going to switch over to Cypher. Hopefully this will work smoothly. This is the first time I'm using this presentation platform. So I'm now logging into Cypher. Cypher is a cloud-based system. Anyone with internet access can access it. And you should be seeing the home page right now, or the main login page for Cypher. So as you can see, just want to say a couple things before I dive into these documentation examples. The site design is very clean and easy to use. The program was designed to be easy to learn and use for clinicians, coders, and anybody in the administrative setting or clinical setting. I want to explain that Cypher was built with 3 fundamental principles in mind: speed, ease of use, and clinical documentation guidance. And Cypher includes every code and condition in ICD-9 and ICD-10, but it can be customized by specialty in one simple click. So if you see here right now, the program is being customized for cardiology because I've selected my cardiology as my specialty. If I go in and say I'm a family practitioner, these top 50 conditions on the left will customize by that specialty. And then you see we have all these specialties loaded right here. So let me go in and begin. I'm going to actually start with asthma. So I can just start typing in my search, like a Google search, and you'll see the results come up quickly. Everything that's in the ICD-9 or ICD-10 code set relative to asthma. And I just click on asthma. Now I'm taken to the next page, which is asking me to provide some specification. And it's actually providing me with details around the new definitions for severity and frequency for asthma. So based on this, I could click on mild persistent. Now it's also asking me to specify if there are any complications or exacerbations. Based on this, I could say if it was true that my patient had acute exacerbation. And last, it's going to ask me if there are any additional factors I should be considering, such as tobacco use or other comorbidities or exposure to tobacco or smoke. So I can say that my patient is a tobacco user, and also the patient has COPD if that is accurate and relevant. I click on Complete Diagnosis, and I'm taken to a summary page. You see we're now in document mode. And you can see here that I'm presented with the detailed ICD-10 condition descriptions for the three conditions and also the tobacco use that I specified. I have my ICD-10 code and my ICD-9 code or codes. In the case of asthma, there are multiple codes because in ICD-9 you have intrinsic or extrinsic. And let me just scroll down quickly here to show you something that really differentiates Cipher from any other products out on the market. We've created a library of clinical documentation improvement monographs, or CDI monographs. We currently have over 350 of these monographs covering all the major conditions, and it's an expanding library. And what a monograph is, it's really a summary of the key points you need to know when you're documenting a condition accurately. So what we've provided are documentation tips in ICD-9 or in ICD-10. As I mentioned earlier, you can use the system today for ICD-9, so you want to make sure you're documenting your intrinsic or extrinsic, any type of severity or exacerbations. We list all the common comorbidities, so this is where our CDI experts, either physicians such as Dr. Lowe or other CDI experts, have identified that for certain conditions, these are the most frequent potential complications and comorbidities that may exist. So it's just a reminder that you need to be thinking about these things in order to accurately document your patient and their full picture, their severity of illness. We've included new definitions that may be included with ICD-10. And also some code or regulatory tips and guidance are also incorporated into the system. The ICD-9 codes are here. So as I mentioned earlier, with asthma, you have your intrinsic or extrinsic. So now let me go through and document diabetes. And what I can do here is I can either add to this record, or I can document a new patient. So as we talked about, many patients have multiple complications and conditions. We'll just say add. I want to add this. Now, if I type in diabetes, I can type in diabetes, or again, in a time-saving fashion, if I have a shortcut or an alias, I can type DM2. I click on my DM2, and now you see the program is actually asking me to specify all existing complications from the left, and that if multiple complications exist, I need to document the multiple complications separately. So in this case, let's say that my patient has circulatory complications with their type 2 diabetes. It's going to ask me if there's any gangrene associated with peripheral angiopathy, and I say no, without. And lastly, it's going to ask me for additional factors and comorbidities that I should be thinking about. So the documentation of the long-term insulin use, and also any common comorbidities. Typically, the common comorbidities with diabetic patients are other diabetic comorbidities, although there certainly are others. In this case, we'll just say there's none, complete diagnosis. And you can see that my summary page now, my documentation page, includes those two new codes, the type 2 diabetes without peripheral angiopathy or without gangrene. And then the insulin Z code is on here as well. And if I click on this type 2 diabetes, you can see that the monograph shows up at the bottom for the diabetes, and I can look at the docu-tips as well. And what's important here is also you want to document all complications that are due to the diabetes in your clinical notes. So I'm going to take a look now at the femur fracture, since we talked about femur earlier, and that's all of the injuries and fractures are pretty complicated from a documentation and coding perspective in ICD-10. So I'll say, let's go to a new patient. I could type femur fracture here, or I can also have it on my favorites box to save myself time. Again, always thinking about saving time. So now the screen here for specify looks a little bit different. What the documentation guidance panel is asking you to do is specify using these clinical filters. So if I say, what is the episode? It's my initial episode. What's the laterality? These are all the things you need to be thinking about documenting, but the program just walks you through. It's like having a CDI expert, sitting there, right by your shoulder. The wound class, in this case, you do have to provide some specificity about the wound class. And if you don't know what any of these things are, again, just look at your documentation guidance. We have the Gustilo classification, explanations, and definitions listed along the side. So based on wound class, I could say it's an OPIC grade 1. Is it displaced or non-displaced? Displaced. And in this sense, healing would not be relevant since it's my initial episode. So now what I need to do is to specify the anatomy. Again, the femur is a very large bone. So what part of the bone is broken? We'll say the head and neck. We do have to provide some more specification around what part of the head and neck, because even the head and neck is pretty large. So we'll say it's the base of the neck. And lastly, it's going to ask me for any additional factors. In the case of the injuries, this is where you hear the cause and location codes come into play. So if my state or payer requires me to document the cause and location, I can flag that I need to remind myself to document that. If blood alcohol was involved, you should be, documenting that. And also if any comorbidities were involved. So, blood loss anemia with the fracture, any other bone fractures, if it was car accident or something like that, you'd want to make sure you're documenting all of that as well. In this case, we'll just say complete the diagnosis. So I'm taken to my summary page, and you can see here I have my detailed femur fracture description. I have my 7-digit ICD-10 code, my ICD-9 code. This little icon is, again, just reminding me, look, this is an injury code, so you may have to document your cause and location. And if I forgot to document it or I need to document, I could just add it to my record. I say add. If this person fell, I just type fall. And you can see all the different, reasons for falling. So if they fell off of a ladder and it was the first time they fell off the ladder and there was no fire involved, there we have my fall code. And I can, if I wanted to say they fell in an apartment or a home or on a boat, you can put all of that in here as well. And you just would say add and type in boat or apartment, etc. Everything is included in Cipher, so it makes it really easy for you to just look it up and have it right at your fingertips. So the last example I'm going to do is chronic kidney disease. And let me see here. Let's see, let's go to new patients. Okay, again, I could type chronic kidney disease, or I could just type in CKD, what it's doing now is it's telling you to specify if the chronic kidney disease is due to another underlying cause. So you got to think about that. Is it due to heart failure? Is it due to diabetes or some other problem that the person had? You should be documenting that. Now also the stage. Is it stage 1, 2, 3, or 4? You have your definitions here. We could say it's stage 2 mild. Now again, it's just giving you some prompts here about thinking about underlying causes. If those are relevant, you should be documenting that. Any additional factors, if there's a transplant and any comorbidities that might be present, you would just click on those and save it. You're taken to your summary page, and here you have your detailed chronic kidney disease stage 2 with your ICD-10 code and your ICD-9 code. And again, you have your monograph down here as well. So that is just a quick overview of how easy and simple and fast Cipher is used and can be used to document and help you document accurately and specifically. And now Dr. Lowe and I are going to take you through and summarize a few ways that you can, I'm going to stop sharing my screen, that you can actually sharpen your documentation skills today and inside your clinical team. So we just need to get back into the slide presentation. Karen, I'm not seeing the slides.
I'm on it.
Monique, there are a number of questions about Cipher. You might want to keep Cipher up for a moment and answer those questions that have been sent to you.
Sure. Let me take a look here on the panel. Do you want to, Jackie, can you read me one of these? There are several questions that have come in, so I didn't know if there was one specifically that you would like me to address.
Yes, I think I could generalize that most of the questions deal with whether or not Cipher interfaces with an EHR, people would like to see whether or not you can put in an I-9 code into the search bar, and they're also curious about the price.
Okay, so I'll take all three of those quickly in order. Right now, Cipher is built as a standalone product, so anybody with a web interface or a web browser can access it today. You can go online to our website, icdlogic.com, subscribe, or if you have multiple members of your staff that want to come in, you can subscribe as well, and you get volume discounts. The system was built on an application programming interface, so it can interface directly with EHRs, and we are actually in discussions right now with several leading EHRs about how to have Cipher interface more directly into their problem list and also have it as a reference within the workflow. And secondly, let me see, what was the other question? The price. The price right now, the standard kind of off-the-shelf price that we're offering is $35 a month, but I'll talk about a special price for Paycom members and participants of this call at the end of the presentation. So it's priced to be very affordable. It's meant to be a tool that can be used by everyone, and we can you can again you have the volume discounts, and then lastly ICD-9 codes. I don't want to switch back to the program a second because I think we're having some technical difficulties when I go back and forth between the program and the slides. But the system, you can enter in an ICD-9 code as well into that search bar. And what's interesting is it will guide you through. You may have an ICD-9 code memorized in ICD-9, like something like 585.6 for chronic kidney disease. If I typed 585.6 into that search bar, it would guide me through that those same steps that we saw for chronic kidney disease and take me through the detail that I needed to get to a detailed ICD-10 code. And typically what happens is the ICD-9 code at the end of it is a little bit different than the ICD-9 code that was entered in first because it's more specific. So that answers those three questions. We did spend a lot of time with the delay of ICD-10 to incorporate the ICD-9 docu-tips, the ICD-9 lookup functionality. So again, these are all time-saving mechanisms and mechanisms that make the product relevant today for use in your clinical documentation and coding. So why don't we move on here for a moment? Dr. Lowe and I are going to go through a number of ways that we think you can help your staff and your clinical team sharpen their documentation skills today while you're transitioning to documenting for ICD-10. So Will, why don't you go ahead and take that?
Yeah, thank you so much, Monique. Let's face it, physicians are trained to make diagnoses, not to assign codes. Physicians should ditch the code books and learn the functional features of ICD-10 as it pertains to the treatment of their patients.
And practice managers should focus on some of the emotional drivers that physicians respond to, not really wagging your fingers or preaching, but helping your physicians see that if they improve their clinical documentation, they'll make positive progress in care quality. Don't make it all about the practice, make it about the patient, and also quality scores that the physicians are going to be rated on going forward.
Yep. Practice managers should investigate workflow tools that help physicians learn while they work. In addition to Cipher, there are other e-learning tools like Implement HIT and software tools like DocEdge and iDocument.
And taking the time to create a culture inside your practice where you as a practice manager or physician become an ICD-10 or CDI champion, recognized for your leadership skills and in understanding that good clinical documentation will lead to better patient care.
Physicians should use concurrent and retrospective reviews of patient charts as a means to learn from mistakes and to enforce best practices.
And let's not forget, there's nothing like peer pressure and competition to cause positive changes to occur. Excuse me. Deep down, we all want to be recognized when we do a good job. So be lavish with your recognition and give lots of shout outs when there's another physician in the practice who's documenting accurately and correctly.
Templates are a great way to ensure that documentation is complete and consistent.
And you should be getting tools in place now and start pilot testing them. Don't wait until the summer or September to realize that you aren't prepared for the changeover, because there are a lot of moving parts and the whole process of clinical documentation is going to require some changes in behavior. So with that, I'd like to announce today we're announcing a free trial for PACOM, a free trial of Cypher. And in exchange, participants will get to use Cypher free of charge. Excuse me, folks, I'm grappling with a cold here. Let me just clear my throat. Why are we offering this to you for free? Well, it's simple. We want all physicians to know about ICD-Logic's affordable ICD-10 tool and how fast and easy it is. And what better way to accomplish this than to have it vetted by your peers? So participation in this free trial is very easy. You just have to attend a Cypher online orientation session, use it for 2 hours within a 2-week time frame, and complete a brief online questionnaire. In exchange for these 3 simple steps, you can use Cypher software free of charge for 6 months following your trial. Now, participation is limited to the first 25 practices that respond to an email that will be sent to your inbox during this webinar. So act now and become one of the first to take advantage of this free trial offer and the 6 months free access to Cypher. For those who don't participate in the trial, we'd like to invite you to our website. Schedule a demo of Cypher, take a deeper look into it, and you can also take advantage of a special offer, a pricing offer that we're offering for all participants of today's webinar. If you purchase or subscribe to Cypher between now and March 31st and use the code PACOM, you can get a Cypher license for $30 a month per user, which turns out to be $60 less than our current annual price. So you do get a discount on the total annual cost. Cypher comes with a money-back guarantee, so if you're not satisfied, you can notify us within writing within 30 days of activation, and we'll refund your subscription fee and cancel your subscription. We thank you for listening, and now we'd be happy to answer any questions that you might have. So let's see if there are any additional questions here. I will check. I have one question that says, can you use Dragon with Cypher? So right now, Cypher is not integrated with Dragon software. We are looking at that because we've heard of several physicians request to have the voice recognition incorporated into Cypher, but currently we do not have Cypher integrated with Dragon. But that's something that we do want to address going forward. Another question again is, does the program link to an EHR or is it a standalone? I mentioned that earlier that the program right now you can use without, even if you don't have an EHR, but if you do have an EHR, you can use this as a standalone, or we can develop an interface. If you're part of practice, we can actually have you can link out, do your lookup and search, and then have the resulting codes and details sent back into the specified fields within your EHR. So that's all done through application programming interfaces. Let me see if there are any other questions here. Will there be an iPhone app? So right now, Cypher is built with responsive design, so it can be used on a computer, a laptop, a tablet. It can also be used on a mobile phone. But the small phone device is not optimized for Cypher because of when you saw those panels of documentation guidance. So we're working on a native mobile app right now for Cypher, but you can use it on an iPad. It looks beautiful on an iPad or an iPad mini. Let's see another question. $35 a month and multiple providers in our office can use. $35 per month is the price per subscriber. So if you have multiple docs or users in your office, you would need to have individual, subscriptions for each user. And the reason for that is that, as you saw when I logged in, it recognizes that it's me. I can customize my favorites. I can customize aliases. It saves all of my activities, so someone can actually come in and and look, administrators can look at what's happening and how people are using Cipher. On the back end, there are reports that I didn't even go into. So if you want to use it as a training to make sure people are using it in training and coding properly, you can use it as a way to measure that and do remediation. Someone asked, what are the other tools again? As Dr. Lowe mentioned, there are a few other tools similar to Cipher, but none of them incorporate the clinical documentation improvement monographs that we've developed. One of them is called iDocument, and then Implement HIT is more of an e-learning. It's a very effective e-learning platform that delivers ICD-10 learning and documentation learning in bite-sized chunks by your specialty. So that's also a useful tool to know about. Question, how do you suggest this fits into the workflow of the practice? Well, there's a couple ways that it can fit in. Again, if the physician wants to use it to ensure that they're documenting accurately and specifically at the point of care, they can actually have it on an iPad or on a computer screen, and they can toggle between their EHR and this while they're in the problem, assigning the problem or doing their clinical note. It can also be used if they, after hours, if they're doing their documentation in more detail. And they want to make sure that they're including everything they need to include to ensure that the coder or themselves can assign the most specific code and ensure accurate reimbursement. And also coders can use it downstream when they're trying to assign codes to a clinical record. And they can also use it as a tool to provide a targeted query, because you can actually see the clinical decision steps that a user took when they were assigning a certain code. And if there's some kind of if there's a difference between the clinical record and the code assigned, you can go back and say, you have a question specifically about that, if it's laterality or some type of fracture specificity. Let's see. I think we're nearing the end of our session. It is 2:02, so we are going to wrap it up. And just to remind you, as was mentioned in the beginning of this session, you can get your CEUs if you have attended the live session. This session will be available for recording, and we will also be emailing the slides to all of the attendees who participated in today's session.
Thank you so much to Dr. Wilbur-Lowe and to Monique Syed, and especially to everybody in attendance. We know your day is already busy, and we're thrilled to have such a high turnout of folks who recognize the value of information. Being informed and having access to resources makes all the difference for you, your practice, and your patient community. And as Monique said, the CEU certificates they'll be available. Send your request to ceu@paycom.com and include your full name with your credentials so that we can just paste that right into the certificate for you. Let's see. Also reference today's meeting, because we actually do quite a few meetings. So say the Cipher meeting or the ICD Logic clinical documentation meeting. The recording of this webinar will be on the YouTube channel, youtube.com/paycom by tomorrow morning. If you missed a part, or you want to hear it again, or you want to share it with your team, share it with your physicians, the recorded video is free and convenient. We'll also email the slides for today's webinar to all of the attendee registration email addresses. And that email will also provide information for those interested in learning more about Cipher and the free trial. Thank you again, and keep sharing knowledge.